This section is targeted at those who are new to intrapartum fetal monitoring. I doubt there's anybody in the room who fits that criteria. Those who haven't attended an update in a while, and particularly this is around focusing on those of us who want to use this or our collective experience as a resource for teaching the MDT team about fetal monitoring. This is the clinical practice guideline we have from the Institute and the HSE, published in June 2012 and due for updating this year. And I'll make reference to those recommendations from that guidelines as we go on. Just before we look at some of the evidence underpinning fetal monitoring, I think we just have to accept categorically when it comes to fetal monitoring that current practice often requires a degree of specificity that the evidence base of fetal monitoring simply can't support. We demand of or expect the evidence to support a lot of precision within fetal monitoring, and the evidence base doesn't exist to support that. So it's important to bear that in mind. What evidence we do have, when we look at evidence for low-risk women, these are women who are deemed as low risk of the baby developing intrapartum fetal hypoxia, women who have continuous CTG when compared with women who have intermittent auscultation. Those women are more likely to have an abnormal fetal heart rate pattern, more than double the risk, more likely to have an instrumental vaginal, more likely to have a caesarean section for abnormal fetal heart rate pattern, and that's more than double the risk. More likely to have an instrumental vaginal birth, about 30% more likely, and their babies are more likely to be admitted to special care baby units. Women whose babies are monitored with continuous CTG are less likely to have those babies end up with neonatal seizures. Quite an important outcome, consistent across a number of studies. But what we do know from what evidence we have is that when those infants have been followed up long-term, those seizures haven't been associated with any long-term adverse consequences, and particularly neurological deficit, for example. And we have no evidence of a difference in perinatal mortality associated. I think people accept that in the audience here. That's been known for quite some time now. There's very few trials being conducted in the field that's going to add additional evidence to this. And people might argue that, well, actually, Declan, those very rare outcomes like perinatal mortality in a low-risk population or cerebral palsy in a low-risk population, we will never have the evidence. I accept that entirely. So we have to always default back to what's the best evidence that we have. And this is it. That's from the latest Cochrane review, which was updated in February of 2013. That follows on nicely from the recommendations in the Irish guidelines and in other international guidelines, and I quote, "For a woman who is healthy and has had an uncomplicated pregnancy, intermittent auscultation should be often recommended in labour using either Doppler ultrasound or Penard stethoscope." Just at a point of information, we have very little evidence demonstrating whether the Penard is better than the Doppler or vice versa for intermittent auscultation. When it comes to high-risk women, the same Cochrane reviews that inform lots of guidelines internationally states that when you look at women who have risk factors, there's less evidence. What evidence is there demonstrates that those women are more likely to have a caesarean section. They're even more likely than the low-risk mothers. Consequently, they're less likely to achieve spontaneous vaginal birth. We find an increase in cerebral palsy associated with in infants of mothers monitored by continuous CTG, but we know why that is, largely driven by one small study that had a terribly high cerebral palsy rate in infants weighing less than 1.5 kilos. So in the Cochrane review, we suggest interpret that finding with caution, another way of saying ignore it. And importantly, no evidence of a difference in perinatal mortality or neonatal seizures, despite how counterintuitive it is and what we might think. In terms of evidence generated from randomised trials, we have no high-quality randomised trial-based evidence demonstrating a benefit for continuous CTG monitoring of women with risk factors, which is at odds with most of the recommendations in most international guidelines, all international guidelines, in fact, that I'm aware of. So we have, as in the Irish guidelines, as in other guidelines elsewhere, a recommendation that continuous electronic fetal monitoring be used for women where a risk factor has been identified. And that's what the current Irish guidelines state, that's what the current NICE guidelines state, ACOG, RANSCOG, Canadian Society, etc. But we need to be aware that there is a mismatch between the evidence and what the clinical practice guidelines recommend in that field. And those of you who will be aware of Edwin Schlanderer from St George's questioning the benefit and value of fetal blood sampling recently, and that's gaining some traction. And that commentary is coming from the same Cochrane review that has identified for the past 6 years now at this stage an absence of evidence attributing the use of fetal blood sampling with a decrease or association with a decrease in caesarean section rates. The admission CTG, again from the Cochrane review, I haven't cherry-picked the outcomes just to present half of them to you. These are the summary of the evidence. Women with admission CTG are more likely to have, and this is admission CTG defined as CTG done with diagnosis or signs of labour, more likely to have a caesarean section, more likely to have continuous electronic fetal monitoring during labour, and more likely to have fetal blood sampling, and no evidence of a difference in instrumental vaginal births, fetal and neonatal deaths, or other secondary outcome measures, including neurological morbidity measures. So the guidelines correlate with that well. So the current evidence base does not support the use of admission CTG in low-risk pregnancies and is therefore not recommended as routine. Irish guidelines. So when to use a continuous CTG, if we're saying in the Irish guidelines that we should continuously monitor those who are high risk and offer intermittent auscultation to those who are low risk, how do you make that distinction? Well, there's a nice algorithm available within the Irish guidelines, which due to time we won't go through now, but it identifies maternal and fetal risk factors antenatally, and then intrapartum maternal and fetal risk factors that might develop, and each of those, if present, would suggest the need for continuous CTG. If a woman is having intermittent auscultation, and I often hear people say, the woman has to be continuously monitored. I think if a woman's being intermittently auscultated, she should be continuously monitored, but at set frequencies. So during intermittent auscultation, the monitoring is done for 1 full minute immediately after a contraction, at least every 50 minutes in the first stage of labour, and at least every 5 minutes in the second stage of labour. And we know we record the maternal heart rate hourly. The CTG, if we go into the very basics of it, we want to look at systematic interpretation of the 5 features of the fetal heart. And the really interesting thing is that in guidelines internationally that have come out since 2001, there is no guideline in Europe that I'm aware of that actually defines anymore what a variable deceleration is or what an early deceleration is. They just take it as given that people understand that, and that's why I think we're left with such huge variability in the interpretation. So we look at the 5 features: baseline rate, baseline variability, accelerations, decelerations, contractions, and then all of those inform a plan of care. I'm going to speed up through some of this. Lots of you know a lot of this, so bear with me. The baseline fetal heart rate is the average of the baby's heart rate taken over a 5 to 10 minute period. It's expressed in beats per minute, and the normal range is 110 to 160. And then in most classification systems that have fed out from Nice, for example, including the Irish guidelines, they will classify each of the features, baseline rate, baseline variability, accelerations and decelerations, into reassuring, non-reassuring or abnormal. So here you have your different criteria for classifying the baseline fetal heart rate. 110 to 160 is reassuring, 100 to 109 non-reassuring, 161 to 180 non-reassuring, less than 100 or greater than 180 is abnormal. And straight away you start to see this level of precision that we're trying to hammer into fetal assessment is quite challenging. So for example, apply that mechanism to the baby now who's 32 weeks gestation. Straight away you start thinking, okay, now that informs the classification. What do I do in that situation? Baseline variability, which is a measure of the autonomic nervous system functioning, and it's the degree of variation in a 1 minute period, excluding accelerations or decelerations. And the idea here is that we would move away from terms like poor, reduced, flat, and trying to objectify the amplitude of variability that appears in the tracing. And that's done by taking a 1 minute portion of the tracing you feel best reflects the overall pattern of variability. It is subjective. And taking the lowest value from the highest value in that 1 minute period, and checking yourself, going to another minute and thinking, okay, let's choose another minute. I should get near enough the same answer. If I'm getting 2 very different answers, I've done something wrong probably. In terms of baseline variability, it's regarded as reassuring if you have 5 beats or more for up to 90 minutes. up to 40 minutes. Between 40 and 90 minutes is non-reassuring, and greater than 90 minutes is abnormal. Most of you in the room here were trained at a time when the baseline variability would have been regarded as 10 to 25 beats a minute, and that has driven lots of traces that I would see. People would write down the variability as non-reassuring, when in actual fact it is more than 5. Might be 5 to 10, for example, still within the reassuring category. An acceleration, we know this, an increase in the baby's heart rate, 15 beats above the baseline, lasting 15 seconds or more, excellent indicator of fetal well-being. If they're present, they're reassuring. If there's none for 40 minutes, it's non-reassuring. An important point is that we use the word reactive sometimes to write down CTG reactive to refer to a tracing as a global summary assessment. The term means the presence of 2 or more accelerations in 20 minutes and nothing else. So it only offers information on the presence or absence of accelerations over a 20-minute period. That's all. It makes no commentary greater beyond that. I think we need to be cautious in how we use that term. What we don't know is if you have a tracing that meets all the parameters of being a normal tracing, but doesn't have accelerations, what the clinical implications or predictive value of that might be because of an absence of evidence in this space. Decelerations, 4 types of decelerations: earlies, lates, variables and prolonged. An early deceleration has a gradual onset and a gradual return to baseline. The onset of the deceleration, the onset of the contraction, was going to draw all these out for you, but I think we're stuck for time. I might make the video afterwards with those drawn out. The fetal heart rate reaches lowest point at the peak of contraction. The baseline is returned to the baseline at the end of the contraction, and they're most commonly due to head compression, and therefore you see them late in the first stage and the second stage of labour. People would say that they're a mirror image of the contractions. I have yet to see that. And it's very, very rare would you see true uniform early decelerations that mirror the contractions entirely. The assumption would have been that the most commonly observed decelerative pattern during labour was early decelerations, but it's not. We know it's variable decelerations that are the most common. They're not associated in isolation with hypoxia, acidosis or low Apgar score, but if the pattern is persistent, it should be observed carefully because it may change. Depending on the classification system you look at, in the Irish classification system, they're classified as non-reassuring, as they are in many countries, which raises an issue on the second stage of labour. A lot of women will have early decelerations, won't they? So you'll immediately be classifying that aspect as non-reassuring. And if you have one feature non-reassuring, the tracing is going to be suspicious, isn't it? Yeah? So you're classifying the tracing as suspicious, and the midwives and obstetricians' plan might very reasonably be continue and observe and reassess in 10 minutes or delivery anticipated next, whatever it might be, very reasonably. So it has never sat well with me, the classification of tracings, and I'll speak more of that in a second. Late decelerations, now these are associated with hypoxia, acidosis and low Apgar score, but most infants who have late decelerations will not be hypoxic, not be acidotic, will not have a low Apgar score, but there's a greater risk that they will be. They start at or after the peak of the contraction, not necessarily after the contraction, at or after the peak. Usually proportional to the contractions, in that the longer the deceleration, the longer the contraction, usually the longer the deceleration. And as with any deceleration, if you've any type of decelerations of any depth, including less than the 15 beats, and they're persistent with each contraction, we should be concerned. And you do see those patterns. Late decelerations in the Irish system are classified as abnormal, meaning the tracing would automatically be classified as pathological. 2, I will come on to this in a second, 2 non-reassuring or 1 abnormal. Variable deceleration has unlike late decelerations and early decelerations which have gradual onset and gradual recovery, variable decelerations have a sudden abrupt onset. They're caused by the baroreceptor response to umbilical cord compression, most commonly. They can occur any time during the contraction phase, including with decelerations. So the thing we need to get our head around is, if you've got decelerations occurring with contractions, they could be earlies or variables. Sometimes there's a message, I think, promulgated that the presence of early and late type decelerations is a variable pattern. That's not the case. They have their own unique visual features, and that is driven largely by their abrupt onset and their rapid recovery. May or may not have shouldering. Yeah. The typical variable decelerations for less than 90 minutes should be regarded as reassuring, which is why it's really important to be able to classify the decelerations appropriately, because that can inform your management, that classification as to whether they're earlies or whether they're variables. If I'm asked to look at a tracing, and just to give a comment on a tracing, the few things I would look at, the first thing is the paper speed running at 1 centimetre a minute? Second thing is it definitely a fetal heart? Third thing is, if there are decelerations, the question I ask is, are they gradual onset and gradual recovery as a pattern? If yes, they must be earlies or lates. If no, they're variable. In 99% of the cases, that will be the case. And it helps you very quickly get down to the classification of the decelerations. And of course, there's a whole clinical picture that needs to feed into that subsequently. There are over 40 different types of atypical variable decelerations. And with Michael's permission, I'm going to go through them all with you now. They are anything that changes the typical shape of a variable deceleration, which is your small shoulder beforehand, abrupt onset, rapid recovery, and a small shoulder afterwards. What do we mean by abrupt onset and rapid recovery? We don't have any guidelines in Europe on that. The American College have a nice definition. They say from the baseline to the nadir, the lowest point of the deceleration, 30 seconds, and 30 seconds to come back up to baseline. So a minute would be, they would regard as abrupt onset, rapid recovery. As a pattern, the focus is not on individual decelerations, but as a pattern, and which is interpreted in the context of the overall clinical picture. Prolonged decelerations are very easy. The deceleration lasts at least 2 minutes. Abrupt onset usually drops by at least 30 beats below the baseline. They vary in relation to the contractions and a gradual recovery to the baseline. And in terms of classification, if it lasts for less than 3 minutes, it's non-reassuring. If it lasts for more than 3 minutes, it's abnormal. It does mean often that when a midwife is calling for or referring for obstetric review or senior midwife review because of a bradycardia in a particular room, sometimes that referral is in the presence actually of a prolonged deceleration rather than a bradycardia. Tachycardia, baseline greater than 160. Need to identify the cause. Is it prematurity, fetal movement, maternal infection or pyrexia? The one really worried about fetal hypoxia, or is it maternal dehydration? But also be concerned, and certainly know the clinicians, experienced clinicians in the room will know this, be concerned about the rising baselines, even within normal parameters. Mothers admitted baseline fetal heart rate 120, rises to 140. Be concerned about why that is the case. The fetus's first response to hypoxemia is an increasing heart rate. Bradycardia is a baseline less than 110, and if you have a loss of variability and decelerations during a bradycardia, that's not a good sign. But the converse is also true. You could have a post-term infant, for example, with a baseline fetal heart rate of less than 110, and all other parameters are normal, and you might be very happy, and that might be reassuring. What's missing entirely from any classification system currently available in terms of CTG classification is the contraction assessment. It's missed. It's not discussed at all. So as helpful as the last NICE guidelines in interpartum care were, all 680 pages of them, contraction assessment isn't mentioned once in the guideline. 4 things we're looking interested in contractions: the frequency, duration, intensity and resting tone. An important point I wanted to make here was your hand and palpating contractions is much more important than reliance on the tachograph, which will tell you the frequency and the duration only. This is the classification system from the Irish guideline. Some similarities to the NICE guideline, some minor differences. So what it does is it takes the 4 features of the fetal heart rate: the baseline rate, the baseline variability, and it's not beat-to-beat variability. We can't see each individual beat on machine running at 1 centimetre a minute because it uses a function called autocorrelation. It's actually averaging the beats continuously. Decelerations and accelerations. It takes those 4 features. If all of those 4 features fall within the reassuring category, the tracing is classified as normal. if one or more of the, if one of the features falls into the non-reassuring category, the tracing is classified as suspicious. And if two of them fall into the non-reassuring or one into the abnormal category, the tracing is classified as pathological. So very quickly, you can work out yourselves that you're going to have a large number of interpartum CTGs. Very few will actually be classified as normal. And that's a concern. When you're using language like pathological tracing, plan, continue and observe, reassess in 10 minutes might be a very reasonable plan of care, given the clinical scenario that's unfolding in that situation. When I teach about fetal monitoring, I ask that people consider very carefully documenting the baseline fetal heart rate, baseline variability, accelerations, decelerations, contractions, and an appropriate plan of care. And personally, I don't think it matters how it's classified. And I have some good reasons for saying that now. The new NICE draft guidelines on interpartum care that are coming up are heavily critical of the current classification system into normal, suspicious and pathological, for the very reasons I've suggested, in that the evidence doesn't provide that level of specificity that we think it does. So that will change, I imagine, internationally. And you see that in practice. It's more reflective of this isn't as clean as we would like it to be in clinical practice. Women present at different stages of labour, different parity, for example. If you change the one thing, parity, given the same tracing, the same clinical circumstances, your whole management, as you know, could alter. Yet this classification system doesn't take that into account. So summary, intermittent auscultation for women who are low risk, continuous CTG for women with risk factors, which is recommended in the guidelines, but the evidence, there's a disconcordance there between that and what the evidence says. Admission CTG is not recommended as routine. If we are using intermittent auscultation, then it should be done properly and effectively, regardless of the setting. We should be using systematic interpretation of the CTG hourly and documenting a plan of care from the interpretation. And the classification of CTG tracing is a blunt instrument. I'm not the only one holding that view. And its importance of documenting a plan of care. So Michael asked us for one take-home message, and mine was to adopt a genuine multidisciplinary approach to fetal monitoring education. And then, like everybody else, I'm going to give two things. And CTG is not innocuous. Consider carefully its benefits and harms and inform women. I know of very few other interventions we do that will double the risk of major surgery, and yet I have not heard many clinicians advise women of those risks of unnecessarily continuously monitoring women during labour. Thank you.